So let's start with the first one, Huntington disease.
Okay, Huntington's. So the mechanism here is a trinucleotide CAG repeat expansion in the Huntington HTT gene on chromosome 4.
Okay, CAG repeats, too many of them.
Exactly, way too many. This leads to a protein that's too long, and it becomes toxic. It's what they call a toxic gain of function.
Right.
And this causes atrophy of the caudate and putamen, key brain areas, and you also see ex vacuo ventriculomegaly.
Meaning the brain tissue shrinks, so the fluid spaces look bigger.
You got it. This whole process messes with neurotransmitters. You get decreased dopamine, GABA, ACEs, and ultimately it leads to neuronal death via glutamate excitotoxicity via NMDA receptor binding. Basically, nerve cells die from overstimulation.
Wow, that's a cascade. We got an email from Sarah about her father. His story really illustrates this, doesn't it?
It really does.
Yeah.
Sarah mentioned her dad was, really vibrant, but in his 40s, he started getting fidgety, couldn't sit still.
Subtle at first, I imagine.
Very, but it progressed to constant involuntary jerks. That's the classic chorea you hear about.
Yeah.
But maybe even harder for Sarah was the personality change. He got irritable, just wasn't himself, and his memory started slipping.
That sounds incredibly difficult.
The MRI confirmed it showed that atrophy in the caudate and putamen and the enlarged ventricles, the ex vacuo ventriculomegaly.
And the genetic test nailed the diagnosis.
Yep, confirmed Huntington's, pinpointed that CAG repeat expansion. Sarah said they're managing the chorea with VMAT inhibitors, things like deuterbenzine, but it's a progressive disease.
His story really drives home that it's not just the movements, it's the whole person that's affected.
Absolutely. The cognitive and psychiatric aspects are huge.
Okay, from that genetic condition, let's shift to probably the most well-known dementia, Alzheimer's disease. How does that start in the brain?
Well, with Alzheimer's, you're looking at widespread cortical atrophy. The brain literally shrinks. You see narrowing of gyri, the folds, and widening of sulci, the grooves.
So just overall shrinkage.
Pretty much. And the hallmarks pathologically are these senile plaques. Those are clumps of beta amyloid protein outside the cells in the gray matter.
Plaques.
And then inside the neurons, you have neurofibrillary tangles. These are made of hyperphosphorylated tau protein.
Tau protein, right.
They're basically insoluble tangles that mess up the cell's internal transport system. And the number of tangles correlates with the degree of dementia.
So more tangles, worse dementia.
Generally, yes. You also find Hirano bodies, these little protein rods, especially in the hippocampus, the memory center.
We heard from a caregiver about her grandmother. Her experience really paints a picture of this.
It does. Her grandmother was sharp, around 70. Then she started misplacing things more often. Then asking the same questions over and over.
Classic signs, unfortunately.
Yeah. Then she started getting lost, even in her own house. The doctor explained it as this gradual, relentless decline because her brain was shrinking, especially those memory areas.
Did they do imaging?
They did. An MRI showed that diffuse cortical atrophy. Now, you can't see the plaques and tangles on a standard MRI that needs an autopsy for confirmation.
Right.
But based on the clinical picture, ruling out other causes, the diagnosis was Alzheimer's. She's on medication like Donepezil, an acetylcholinesterase inhibitor.
Does that help much?
It can offer some modest cognitive improvement, maybe slow things down a tiny bit for some people, but it doesn't stop the disease progressing.
It's just such a slow erosion.
Heartbreaking.
It really is.
Okay, so Alzheimer's often starts with memory. But what about dementia, where personality changes are the first thing you notice? That leads us to frontotemporal dementia, right?
Exactly. FTD. Here, the damage is focused frontotemporal lobe degeneration. The front and/or temporal lobes of the brain are shrinking.
And those areas control.
Things like executive function planning, judgment, and behavioral inhibition. Your social filter, essentially.
Oh, okay.
Pathologically, inside the neurons, you often find inclusions of hyperphosphorylated tau, but they look different. Often round, they call them PIC bodies.
Oh.
Or you might find ubiquitinated TDP43 protein inclusions.
PIC bodies, got it. We had a listener call about her brother. His story was quite different from the Alzheimer's one.
Yeah, it often is. She said her brother was usually quiet, maybe late 50s. Then he started making really inappropriate jokes.
Out of character. Totally. Losing his temper easily and doing odd things like hyperorality, putting things in his mouth that aren't food.
Whoa. But his memory was okay.
Surprisingly, yes, especially early on. But his judgment was just gone. An MRI confirmed significant atrophy in his frontal lobes.
So it really highlights that early, striking change in behavior and personality, not memory loss first.
Precisely. That's a key differentiator from Alzheimer's, especially in early onset cases. And unfortunately, there aren't any treatments that modify the disease itself. Management is really about supporting the patient and caregivers dealing with symptoms like agitation.
It sounds incredibly challenging, like dealing with a completely different person sometimes.
It can be, yes.
Okay, that distinction is really important. Let's pivot to another common type of dementia, but one caused by blood flow issues, vascular dementia.
Right. Vascular dementia is pretty straightforwardly the result of multiple arterial infarcts and/or chronic ischemia.
So lots of small strokes or just poor blood supply over time?
Exactly. Parts of the brain don't get enough oxygen and nutrients, and the neurons die off.
We got a message from a nephew about his uncle's decline, and it sounded quite distinct.
Yeah, the pattern is often different. He described his uncle's cognitive function not as a smooth slide downwards, but as having stepwise drops.
Stepwise?
Yeah, like he'd have a mild stroke, maybe not even obviously recognized as one at the time, and suddenly he couldn't manage his bills anymore, then maybe plateau for a bit, then another mini stroke and another sharp decline.
Ah, I see. Like steps on a staircase down.
That's a good way to put it.
Yeah.
The MRI showed those scattered small infarcts, the areas of damage, and often with vascular dementia, problems with executive function planning, organizing, can show up even before major memory loss.
It's another key difference then.
Mm-hmm. And the crucial thing here is managing those vascular risk factors aggressively. Blood pressure, diabetes, cholesterol.
Right. Controlling those can actually prevent it or slow it down.
Absolutely. Prevention and slowing progression are key. It really underlines the link between heart health and brain health.
Makes sense. Okay, from stroke damage, let's look at dementia linked to a specific infection, HIV-associated dementia.
Right, HAD. This involves subcortical dysfunction associated with advanced HIV infection. It's not usually the virus directly infecting neurons in large numbers, but more the inflammatory response.
Subcortical, so deeper brain structure.
Yes. You see cognitive deficits, gait disturbance, irritability, and depressed mood. Imaging shows diffuse gray matter and subcortical atrophy. And under the microscope, a key finding is microglial nodules with multinucleated giant cells.
Microglial nodules.
These are clusters of activated immune cells, microglia, often fused together, reacting to the virus in the brain.
A friend told us about someone named David. His case seems to fit this picture.
It sounds like it. David had HIV, stable for years on treatment, but then he started having memory problems, confusion, his walk became a shuffle.
Gait disturbance, yeah.
And his moods were all over the place. Doctors diagnosed HAD. They explained it was due to that widespread subcortical atrophy, even though his viral load was controlled systemically.
So it's not always directly tied to high virus levels.
Not necessarily in the blood, but the virus can still cause issues within the central nervous system. It's often a diagnosis of exclusion, ruling out other infections or problems.
In treatment.
The main thing is optimizing the antiretroviral therapy, RT, to ensure good penetration into the brain. And interestingly, they mentioned avoiding one specific drug, efavirenz, because it can sometimes cause CNS side effects itself.
Right, so tailoring the HIV treatment is key.
Absolutely. It shows how a virus we think of as systemic can directly impact brain function and structure.
Okay, shifting gears now from infections and dementia. Let's talk about pressure, specifically too much pressure inside the skull. Idiopathic intracranial hypertension.
IIH, yeah. Sometimes called pseudotumor cerebri, it's defined by increased ICP, intracranial pressure, but without an obvious mass or structural cause. It seems to be associated with dural venous sinus stenosis.
Narrowing of the veins that drain the brain.
Exactly. That narrowing seems to impair how cerebrospinal fluid is absorbed, leading to pressure buildup. This then affects the optic nerve you get impaired, optic nerve exoplasmic flow, which results in papilledema.
Swelling of the optic nerve where it enters the eye.
Right. You can see it on an eye exam.
We heard from a patient, a woman in her late 20s, obese, who had some pretty distinct symptoms.
Yeah, the demographic is quite typical. She described months of really bad frontal headaches, worse when she woke up.
Morning headaches, okay.
And transient visual grayouts, like her vision would dim for a few seconds, plus pulsatile tinnitus.
That ringing or whooshing sound?
Exactly, often in time with her pulse. Her eye doctor actually spotted the papilledema first.
Wow.
Neurologists did a lumbar puncture, a spinal tap, and found incredibly high CSF opening pressure. After ruling out other causes, they diagnosed IIH.
It's linked to things like obesity, maybe certain meds.
Yes, strongly associated with obesity, especially in women of childbearing age. Also linked to things like tetracycline antibiotics, excess vitamin A, or growth hormone.
So management involves.
Weight loss is crucial. And medications like acetazolamide can help reduce CSF production, lowering the pressure to protect her vision.
Got it. Protect the optic nerve. Okay, staying with CSF and pressure. What about communicating hydrocephalus?
So communicating hydrocephalus means the CSF can still flow between the ventricles and around the brain, but the problem is absorption. There's reduced CSF absorption by arachnoid granulations.
The structures that normally drain the CSF back into the bloodstream.
Precisely. This often happens because of arachnoid scarring post-meningitis, for example. The inflammation leaves scars that block up the drainage system.
So CSF builds up everywhere.
Yes, leading to increased ICP, papilledema, and potentially herniation if it's severe.
We heard from an aunt about her nephew Daniel
Yeah.
after he'd had meningitis.
Right. After recovering from the meningitis itself, Daniel developed ongoing headaches, problems with balance, became erratic behaviorally, and started having bladder control issues.
That's serious.
It was. Doctors figured out the meningitis had scarred those arachnoid granulations, so CSF wasn't draining properly. Imaging showed enlarged ventricles, and the space around the brain was also full of excess fluid.
So they diagnosed communicating hydrocephalus?
Yes. And the treatment that helped him significantly was placing a VP shunt, a ventriculoperitoneal shunt.
A tube to drain the excess fluid somewhere else, like the abdomen?
Exactly. It bypassed the blocked natural drainage system. His case really highlights how an infection can lead to this absorption problem, causing a global increase in CSF volume and pressure.
Okay, so that's when absorption is blocked. But then there's normal pressure, hydrocephalus, and pH. How is that different? It sounds similar.
It's related, often considered a chronic form of communicating hydrocephalus, but it's distinct. NPH is typically idiopathic, meaning we don't know the exact cause.
No prior meningitis or obvious scarring?
Often not. And importantly, the CSF pressure is elevated only episodically. It's not consistently high like in acute communicating hydrocephalus or IIH.
Oh.
The ventricles expand significantly, though, and this distorts the fibers of the corona radiata nerve tracts near the ventricles. There's no decreased subarachnoid space volume, unlike some other conditions.
Right, and this leads to that classic triad of symptoms.
Yes, the wobbly, wet, wacky triad. We got an email from a niece about her aunt.
Tell us about her.
Her aunt was pretty spry, late 60s. Then she developed this weird shuffling gait, like her feet were stuck to the floor, magnetic gait. That was the wobbly. Then came urinary incontinence, the wet. And finally, a kind of mental slowing, confusion, apathy, the wacky, but not classic Alzheimer's type memory loss.
Wobbly, wet, wacky, usually in that order.
Often starts with the gait disturbance, yes.
Yeah.
The MRI showed those really dilated ventricles, much larger than you'd expect for her age or degree of brain shrinkage elsewhere.
And the key diagnostic test.
A high-volume lumbar puncture. They removed a large amount of CSF, and temporarily her walking improved. That's a strong indicator for NPH.
And the treatment, also a shunt.
Yes, a VP shunt can be very effective for NPH. It's considered a potentially reversible cause of dementia, which is a huge differentiator from things like Alzheimer's.
That's a critical point. Okay, so communicating and NPH involve issues with flow around the brain or absorption. What about non-communicating hydrocephalus?
This one is different. Non-communicating or obstructive hydrocephalus means there's a physical structural blockage of CSF circulation within the ventricular system.
So inside the brain's fluid pathways themselves.
Exactly. Something is blocking the flow from one part to another. Common causes are stenosis of the aqueduct of Sylvius, a narrow channel or a colloid cyst blocking the foramen of Monroe, or maybe a tumor.
So the fluid backs up behind the blockage.
Precisely. CSF builds up, and the ventricles upstream from the obstruction get enlarged, causing increased pressure.
We had a parent call about their baby, Michael. This sounds relevant.
Yes, tragically relevant. Michael's head started growing way too fast, alarming head circumference increase. He was very irritable, cried like he had terrible headaches, and had projectile vomiting.
Classic signs of high pressure in an infant.
The MRI found the cause. A tumor in his fourth ventricle, physically blocking the CSF outflow. Doctors called it non-communicating hydrocephalus.
A direct obstruction.
Yes. In infants, you see that macrocephaly, bulging fontanelles. In older kids or adults, it's more typical increased ICP signs. He needed emergency surgery for a shunt to relieve that pressure. It was life-threatening.
A stark difference. A physical blockage needing immediate relief. Okay, we've covered different types of true hydrocephalus, but what about ex vacuo ventriculomegaly? It sounds like hydrocephalus, but you said it's not quite the same.
Not at all, functionally. It's really important to distinguish. Ex vacuo ventriculomegaly is the appearance of increased CSF on imaging, but it's not due to a fluid buildup problem. It's actually due to decreased brain tissue and neuronal atrophy.
So the brain shrinks and the fluid just fills the space left behind.
Exactly. You see it in conditions we've already discussed, like Alzheimer disease, advanced HIV, frontotemporal dementia, Huntington disease. The ventricles look bigger on the scan, but the ICP is normal.
And the NPH triad isn't there.
Correct. No wobbly, wet, wacky. It's a passive filling of space.
A listener mentioned her mother's neurologist showing scans during your Alzheimer's progression.
Yeah, she said the neurologist pointed out the larger-looking ventricles, but specifically explained it wasn't hydrocephalus causing pressure, but rather hydrocephalus ex vacuo, hydrocephalus from a vacuum or empty space created by the brain atrophy.
So it's a sign of the underlying neurodegeneration, not a separate fluid problem to be treated with a shunt.
Precisely. You'll often see correspondingly widened sulci, the grooves on the brain's surface, indicating general atrophy. Management focuses entirely on the underlying disease causing the brain shrinkage.
That's a really key distinction for interpreting brain scans. Okay, let's shift from fluid and structure to the immune system attacking the nervous system. Multiple sclerosis.
MS, yes. It's an autoimmune inflammation and demyelination of the CNS, that's the brain and spinal cord, followed by subsequent axonal damage.
Demyelination. The immune system attacks the myelin sheath, the insulation around nerve fibers.
Exactly. Myelin is crucial for fast electrical signal transmission. When it's damaged or destroyed, signals get slowed, blocked, or scrambled. And eventually, the underlying nerve fiber, the axon, can be damaged too.
We heard from a woman, late 20s, whose diagnosis journey sounded, well, confusing at first.
It often is. MS symptoms can be varied and come and go. She mentioned her first symptom was painful, blurry vision in just one eye optic neuritis, very common in MS.
Okay.
Then months later, she developed Lhermitti-sign, that electric shock sensation down the spine when she bent her neck.
Oh, wait.
And then her legs felt heavy, spastic. This pattern, different neurological problems separated in time and occurring in different parts of the CNS, dissemination in time and space, is classic for MS.
How did they finally diagnose it?
The MRI was key. It showed those characteristic scattered white matter lesions, often called periventricular plaques, near the ventricles in her brain, and also lesions in her spinal cord. That confirmed it.
And treatment involves?
For acute relapses, high-dose intravenous glucocorticoids, steroids, to reduce the inflammation quickly. Long-term, there are many disease-modifying therapies, DMTs, that help reduce the frequency and severity of relapses and slow disability progression.
She also mentioned something about heat.
Ah, yes, the Uthoff phenomenon. Symptoms temporarily worsening with heat, like after a hot shower or exercise. It's a classic feature due to heat affecting nerve conduction in demyelinated fibers.
Fascinating. Okay, another condition involving demyelination, but from a totally different cause. Osmotic demyelination syndrome.
ODS, yeah. This is usually iatrogenic, meaning caused by medical treatment. It results from rapid osmotic changes, most commonly the too quick correction of hyponatremia, low sodium levels.
So fixing low sodium too fast is dangerous.
Extremely dangerous. But it can also happen with rapid shifts in other osmolytes, like glucose. These sudden, large changes in the body's fluid concentration cause massive axonal demyelination, specifically in the pontine white matter, the pons, a critical part of the brainstem.
Pontine white matter.
Okay. We heard from a caregiver about her mother who was critically ill. Her story was devastating.
What happened?
Her mother had severely low sodium. It was corrected too rapidly in the hospital. A few days later, her speech became slurred, her limbs rigid. She essentially became locked in.
Locked in? You mean conscious but unable to move or speak?
Exactly. She could only move her eyes vertically, aware but trapped. Neurologists diagnosed ODS, explaining the rapid sodium shift had basically stripped the myelin from crucial pathways in her brainstem.
Oh my God. That's terrifying.
It is, and largely irreversible. That's why prevention is absolutely paramount. You have to correct severe hyponatremia slowly and carefully. The rule of thumb is generally limiting the sodium increase to less than 10, maybe 12 MEQL in a 24-hour period.
A crucial lesson in careful electrolyte management. Wow. Okay, let's move to another autoimmune condition, but one targeting the peripheral nerves. Acute inflammatory demyelinating polyradiculopathy, or ADP, a subtype of Guillain-Barré.
Right, ADP, the most common form of Guillain-Barré syndrome, GBS, in many parts of the world. It's autoimmune destruction of Schwann cells, the cells that make myelin in the peripheral nervous system, via inflammation and demyelination of motor and sensory fibers.
So similar attack on myelin, but outside the brain and spinal cord.
Correct. It's often triggered by something, usually an infection like Campylobacter jejuni gastroenteritis a couple weeks prior. The idea is molecular mimicry. The immune system mistakes parts of the nerve for the bug it just fought off. Stress or even vaccinations can occasionally be triggers too.
We heard from a patient who went through this. It sounded terrifying.
It usually is. He said about a week after a bad stomach bug, his legs started feeling heavy, numb, then the weakness just ascended, moved up his body rapidly.
Ascending paralysis.
Classic feature. It led to complete paralysis and he lost his reflexes. The most frightening part for him was when his breathing became labored, needing respiratory support.
Life-threatening. How do they confirm it?
Clinically, it's often suspected strongly. A lumbar puncture is key. The CSF typically shows high protein levels but a normal white blood cell count. That's called albuminocytologic dissociation.
High protein normal cells.
Got it. And treatment. Importantly, steroids are not effective here, unlike in MS relapses. The mainstays are intravenous immunoglobulin, IVA, or plasma exchange, plasmapheresis, to remove the harmful antibodies.
And he recovered.
Yes, slowly. With IV treatment, he regained movement. But it highlights how critical those specific immune therapies are for GBS.
Absolutely. Okay, from an acute autoimmune attack on peripheral nerves, let's look at a chronic hereditary peripheral nerve disorder, Charcot-Marie-Tooth disease.
CMT. It's actually a group of progressive hereditary nerve disorders. They're all related to defective production of proteins involved in the structure and function of peripheral nerves or the myelin sheath.
So a genetic defect affecting nerve components.
Exactly. Different genes can be involved, leading to different subtypes, but the result is slow, progressive degeneration of peripheral nerves, causing muscle weakness and sensory loss, mostly in the limbs.
We had a parent call about their daughter, Sarah. Her symptoms started young.
Yes, often noticed in childhood or adolescence. Sarah apparently always had high arches in her feet and hammer toes.
Common foot changes in CMT.
Then in elementary school, she started tripping a lot, developed foot drop, that slapping gait because she couldn't lift the front of her foot properly, and her lower legs looked noticeably thin due to muscle atrophy.
So weakness and wasting, especially in the legs and feet.
Predominantly, yes, especially early on. Nerve conduction studies and genetic testing confirmed CMT. It's often autosomal dominant, meaning just one copy of the faulty gene is enough.
Is there a cure?
Unfortunately, no cure. Management is supportive physical therapy to maintain strength and function. Orthotics, like ankle-foot braces, IFOs, to help with foot drop and stability, and managing any associated pain or sensory issues. It's about maximizing function despite the progressive nature.
Right, supportive care is key. Okay, shifting back to the central nervous system and infections. Progressive multifocal leukoencephalopathy, PML.
PML. This is a really serious one. It involves destruction of oligodendrocytes, the myelin-producing cells in the CNS, secondary to reactivation of latent JC virus infection.
JC virus. Most people have been exposed to that, haven't they?
Yes, it's very common and usually harmless, stays latent, dormant. But in people who are significantly immunocompromised, think advanced HIV/AIDS, certain transplant recipients, or people on specific immunosuppressive drugs, the virus can reactivate.
And when it reactivates in the brain.
It attacks and kills those oligodendrocytes, leading to widespread demyelination of the CNS, particularly the white matter. Leukoencephalopathy means disease of the white matter.
We heard about Mark, an HIV patient, from his neighbor.
Right. Mark's HIV had been stable for a long time on medication, but then he suddenly developed weakness in one arm, his speech got slurred, he had trouble understanding things. It was a rapid, puzzling decline.
Very alarming.
An MRI showed characteristic patchy areas of demyelination in the white matter, typically without enhancement, inflammation. Tests confirmed JC virus in his spinal fluid, confirming PML. His immune system was weakened, likely a low CD4 plus T-cell count, allowing the virus to reactivate.
What's the treatment for PML?
The main strategy is to restore the person's immune function if possible. For HIV patients like Mark, that means optimizing their antiretroviral therapy, ART, to get the immune system stronger so it can fight the JC virus. There aren't great direct antiviral treatments for JC virus itself.
So boosting the immune system is the best bet.
It's the cornerstone of management, yes, a very serious condition often linked to immunosuppression.
Okay, from a viral reactivation, let's look at a congenital condition present from birth, often with very visible signs. Sturge-Weber syndrome.
Sturge-Weber. This is caused by somatic mosaicism of an activating mutation in one copy of the GNAQ gene.
Somatic mosaicism, meaning the mutation happened after conception and affects only some cells.
Exactly. It's not inherited in the usual way. This GNAQ mutation affects the development of neural crest derivatives, leading to abnormal blood vessel formation.
And that causes the characteristic feature.
Yes. You typically see a capillary vascular malformation, the facial port wine stain birthmark, usually along the distribution of one or more branches of the trigeminal nerve, often V1, the ophthalmic branch.
The birthmark.
Then, on the same side as the birthmark, an ipsilateral leptomeningeal angioma, abnormal blood vessels on the surface of the brain, often with calcifications, and frequently an episcleral hemangioma vascular abnormality in the eye.
We heard from a parent about their son, Leah.
Yes. Leo was born with that classic, vivid, purplish-red port wine stain on the left side of his face covering his eyelid. Later on, he started having seizures, and there were concerns about his developmental pace. His left eye also looked reddish, and there was worry about glaucoma, which is common.
So the skin, brain, and eye involvement.
All linked by that underlying vascular malformation due to the GNAQ mutation. Neurologists confirmed Sturge-Weber. Brain scans showed those characteristic tram-track calcifications along the brain surface following the abnormal vessels.
And management is symptom-based.
Entirely. Laser therapy can lighten the birthmark. Antiepileptic drugs are needed for seizures. And careful monitoring and treatment for glaucoma is crucial to preserve vision. It's a condition where what you see on the skin tells you about potential problems underneath.
Fascinating connection.
Yeah.
Okay, let's move from blood vessels to hormones. Pituitary adenoma.
A pituitary adenoma is essentially a benign tumor of the pituitary gland. It's hyperplasia or overgrowth of only one type of endocrine cell found there.
So one specific hormone-producing cell type goes into overdrive.
Exactly. And the most common type involves lactotrophs, the cells that produce prolactin. So you get a prolactinoma, leading to hyperprolactinemia, too much prolactin in the blood.
We heard from a couple who had a really baffling situation.
Yeah, quite unusual for both partners to be affected, but it illustrates the effects well. The wife, who wasn't pregnant or breastfeeding, started producing milk, galactorrhea, and her periods became irregular.
Classic signs of high prolactin in women.
Meanwhile, her husband experienced a significant drop in libido and even developed some breast tissue, gynecomastia.
And high prolactin can cause that in men too.
Yes, it suppresses gonadotropin release, affecting testosterone. Blood tests confirmed sky-high prolactin in both of them. An MRI showed a small pituitary adenoma, a prolactinoma, in the wife.
And the husband.
He also had one, and his was large enough to press on the optic chiasm, the place where the optic nerves cross. This caused bitemporal hemianopia, loss of peripheral vision on both outer sides.
The massive plaques.
Exactly. For prolaxinomas, the first-line treatment isn't usually surgery. It's medication dopamine agonists like bromocriptine or cabergoline.
And they shrink the tumor.
Yes, they are very effective at shrinking prolactinomas and lowering prolactin levels, often restoring normal function and relieving mass effect. Shows how critical that tiny pituitary gland is.
Truly the master gland. Okay, from hormonal issues, let's go to a severe genetic motor neuron disease starting in infancy. Spinal muscular atrophy.
SMA. This is caused by a congenital degeneration of anterior horns in the spinal cord.
Anterior horns, where the lower motor neurons live. The ones controlling muscles.
Precisely. It's due to an SMN1 mutation, which leads to defective SNRNP assembly. SMN protein is crucial for assembling these SNRNPs, which are vital for RNA processing. Without enough functional SMN protein, those lower motor neurons undergo apoptosis-programmed cell death.
So the motor neurons die off.
Yes, leading to progressive muscle weakness and atrophy.
We heard from a parent about their baby, Lily. Her story sounds characteristic.
It does. Lily was born extremely floppy, severe hypotonia. Her limbs felt like a rag doll's. She couldn't lift her head, had trouble feeding because of a weak suck. And very concerningly, her breathing became shallow, reflecting weakness of the respiratory muscles. Genetic testing confirmed SMA, type 1, the most severe form.
And it's purely motor, right? Sensation is okay?
Critically, yes. Cognition and sensation are completely normal. It's purely a lower motor neuron disease, presenting with that infantile hypotonia, flaccid paralysis, muscle wasting, atrophy, and sometimes tongue fasciculations, twitching.
Is there any treatment now? It used to be devastating.
It's still devastating, but there's been a revolution in treatment. Newer therapies, gene therapy, and antisense oligonucleotides like nusinersen work by increasing the amount of functional SMN protein produced. Often from a backup gene called SMN2, they can significantly change the course of the disease, especially when started early.
That's incredible progress, offering real hope.
Absolutely, a game changer for SMA families.
Okay, our final condition for this deep dive is another motor neuron disease, but one that typically strikes adults and affects both upper and lower motor neurons. Amyotrophic lateral sclerosis.
ALS, or Lou Gehrig's disease. It's defined by combined UMN, corticospinal cortical bulbar, and LMN, brainstem spinal cord degeneration.
Upper and lower motor neurons dying off together.
Yes, progressive degeneration and death of both sets of motor neurons. Most cases are idiopathic, meaning we don't know the cause. A smaller percentage, the familial form, can be linked to gene mutations, famously SOD1 mutations, but others too.
SOD1 superoxide dismutase 1. Okay.
We heard from a patient about how his symptoms started. It was insidious.
How did it begin?
Just a tremor in one hand, then weakness spreading in that arm. Then his speech started to slur, dysarthria. He began choking on liquids, dysphagia.
But both are symptoms affecting speech and swallowing.
Exactly, reflecting brainstem motor and neuron involvement. He also noticed muscle wasting, atrophy, and visible twitching under the skin, fasciculations, those are LMN signs. But alongside those, he had stiffness, spasticity, and exaggerated reflexes. Hyperreflexia, those are UMN signs.
The combination is key for ALS.
It is the hallmark. And crucially, ALS spares sensation, cognition, though some overlap with FTD exists, and bowel bladder control, typically.
So, purely motor degeneration, is there any treatment to slow it down?
There's one main FDA-approved drug shown to modestly slow progression, riluzole. It's thought to work by reducing glutamate excitotoxicity. It can prolong survival by a few months. Other drugs and supportive care are vital for managing symptoms like muscle cramps, spasticity, and especially respiratory insufficiency, which is often the ultimate cause of death.
It sounds like an incredibly cruel disease, trapping a functioning mind inside a failing body.
That's often how patients describe it. Truly devastating.
So we've covered a huge amount of ground. What does this all really mean? We've seen everything from, genetic typos causing toxic proteins in Huntington's to the plaques and tangles of Alzheimer's.
And the immune system attacking myelin and MS, or peripheral nerves and GBS.
Right. Vascular damage and strokes causing dementia, fluid dynamics going wrong in hydrocephalus, pressure issues in IIH.
Viral reactivations like PML, congenital issues like Sturge-Weber, motor neurons dying in SMA and ALS.
It's just an incredible range. And hearing the stories really hammers home how these intricate mechanisms play out in real lives. We really appreciate everyone who shared their experiences.
Absolutely. And you see the common threads too, right? The brain's delicate balance is so easily disrupted genetically, immunologically, vascularly, structurally. And it highlights how crucial careful observation and testing are to differentiate these conditions. Getting the diagnosis right changes everything for management and prognosis.
Thank you so much for joining us on this deep dive. It's been intense, but hopefully illuminating.
Definitely. And maybe leave you with this thought. Consider how understanding these precise mechanisms, which once seemed like total mysteries, is now opening doors. Doors to new therapies, interventions, and hope. What new connections or insights will you look for next time you encounter one of these conditions, having heard these stories?
Keep learning, keep asking questions, and please keep sending us your experiences. We learned so much from them. Until next time on The Deep Dive.